is really what when we talk about bridge to reform, those last two statistics, again, thank you, UCLA, comes from their report, is what we mean. UCLA is predicting, they're estimating that nearly 94% of the LIHP population will be able to be just administratively moved over into the new state plan eligibility group. And the other 6% will be referred to the exchange for consideration of financial help through the advanced premium tax credit and some cost saving measures. Now, the importance of that is for those of us at the federal level who really are, the big push, we want ACA to succeed. And one of the biggest challenges we have right now in getting healthcare reform up and running and to its full potential is really what goes into educating, encouraging, and enrolling. I mean, all of our outreach efforts right now at the federal level is based on that. We really have this huge uninsured population out there, and we're trying to figure out a way that we can educate them, encourage them, get them enrolled. You've done that for the LIHP. That is what is so gushy about this program. You've gone there. The county workers, county members, you've done for the last 2 years, you've done exactly that in bringing on this population. They've been educated about the importance of health care. They've been encouraged to join your program. You've enrolled them. And so the state is left with all the easy work. All they have to do now is just take what you've done and, electronically move them into their state program. So that's where the gushing ends. I'm just going to quickly move to some of the realities of what has to be done over the next 4 months. But again, this is why we're so excited, because you really have done that educating, that encouraging, that enrollment, which is the biggest challenge for those who are working on the rest of the uninsured and getting them into the program. So the reality of the situation, I'm not going to dwell on this because it's not to be, this is for others to talk about, but there's still a lot of work to be done. Over the next 4 months, we need to work through some state plan amendments to get this population into the regular Medicaid program. There needs to be some state plan amendment on eligibility. We need to do one on alternative benefit package, which will be offered to this population when they move into the state plan. And there's also some matching issues, again, because of the 100% funding. We need some plan work on that. There's also a requirement for the state to submit a transition plan to us, which has a lot of extensive requirements, and the state has submitted, officially submitted, one of a plan that we're looking at now. We're trying to help the state because we realize that it sounds easy. I guess it doesn't sound easy. It seems easy to say, conceptually what I see happening is, county workers will take your LIHP program and put it into the meds or the SAW systems, and then that just moves over that gets them into Medicaid. I know it's much more complicated than that, but it seems easy to say. But in doing that, we really need to, you can imagine that there is a lot of work. I can see that there is some work coming up from you and getting your county-specific eligibility system data into the statewide system so they can move into the statewide Medicaid program. And in doing that, I missed my clicker, didn't I? Oh, you did get that on. I didn't think that slide would be able to come on. Anyway, I have put that in there just because I wanted to show that one of the requirements that has to happen before January is the state needs to have approved a transition plan. Don't want to go into the specifics, but just wanted to show you that because it's so busy, you can see that the transition plan is fairly comprehensive and has a lot of elements to it. But in addition to so recognizing that you do have a lot of work to do the next 4 months, we are trying whatever we can at a federal level to help you. We were asked and we have approved I think it came from the county's request to delay redeterminations from October through December of 2013, which means that a county option, if someone's coming up for renewal in the LIHP program, you will be able to delay that redetermination for a year and just get them plugged in to the statewide population. We've also been asked, CMS has also been asked to approve a similar type of delay in redeterminations for the January through March period. We're also working on that. The only reason they didn't come together is we're doing under two different authorities. We waived the redetermination requirement for October through December 2013 through the waiver process. We have to use a different authority to do it for January through March 2014, but we're working on that. So we're trying to help as much as possible to ease the burden on you. And again, we're always concerned about continuity of care issues, as I know you are, and as the state is, to make sure that these individuals can maintain their networks as much as possible, the transition is seamless, and they stay in care. So with that, I'm going to end again with gushing. What more? I mean, there's no more powerful statistic than to say, you've done it. You've done the education, the encouragement, the enrollment. The state now will be able to take 94% of those nearly over 600,000 individuals, move them into the state plan process. And, I just can't say enough about how excited we are about all the hard work you have done. And I just want to leave with one comment. Richard started by saying there are 138 days left until January 1st. It's interesting because that shook me and I realized that if you had not done the LIHP, we would have been standing up here because what we say at the federal level is there are 47 days left because we're focused on October, not January. And I think it's interesting, just the fact that Richard could say to you that you're focused on January shows what significant accomplishments you have made, because for the rest of us, we are getting geared up for October. That's when we really have to start that educating, encouraging, and enrollment. So thank you. I'm very honored to be here with you today.
So now I'd like to open it up for some questions and answers for our panel. So if you'd like, you can come up to the microphones that are set up here, and for the next about 10 minutes, we'll take questions and answers, and it can be to any one of our panel members. To those individuals that are on the webinar, you can send your questions to LIHP Project Transition at dhcs.ca.gov.
All right.
Hello.
Turn this thing on here, huh?
I think they're on.
Okay, good. Randy Hicks, California's Disability Rights Disability Advisory Commission of Sacramento County, which I'm a member of but not representing today. But one of the problematic issues we've been having is that there are some access issues at the clinics. You want to enroll a lot of people into these into these programs here through the county programs, and some of them still have disabilities. They're not Medi-Medi, but they're either transitioning to become that, or they are starting to get healthcare services they didn't have before. A lot of things that's been happening is signage. There's signage issues, there's physical access issues, and there's programmatic issues to enroll people. How is the state, federal, and county working on these programmatic issues to make sure that they can use the service? Because I can tell you, I went to the county clinic in Sacramento County, and there's not proper signage there.
Hi, Randy. It's good to see you. I'll take it on a bigger level. As we move forward with the seniors and persons with disabilities and the transition, we have a lot of requirements on our plans that are then working with our providers on facility site reviews and making sure. So I think it would be important, we can talk afterwards to understand where you're seeing this, so we can talk with the plans in Sacramento and understand how it fits into the requirements under their contract and with the providers to get them ready as it relates both for their current populations, but as we transition the low-income health program and Medicaid expansion, which many of them do also, the population have disabilities, that we're gearing up and making sure that the providers are meeting the requirements both under our Medi-Cal Managed Care contracts as well as the Department of Managed Health Care.
Okay, just then a follow-up question is, for people who are now going to be eligible for this how will they know to be eligible for this? What kind of PSA system are you going to set up? And are they just going to get letters in the mail? It's all of a sudden we don't see you have health insurance coverage and you're insured for this. And are they enrolling a lot of people who are in Medi-Cal into this program here?
Let me say, if I might, because I meant to say it more broadly, and I was going to do it if nobody asked a question right away, just a brief word about our overall marketing that we're doing that's running primarily through Covered California. That is a 3-level outreach. So I want to respond in 2 ways, and then Toby can give you a specific response about the LIHP. But we are at the end of this month, or starting in September, you're not going to go anywhere that you're not going to see coverage expansion messages. They're in 3/4. We had contracts with community-based organizations that were let in May, and that public education is starting. We'll have 20,000 enrollment counselors certified that will be working through the network of trusted communicators within their areas. So organizations that beneficiaries go to for other services will be educated and be able to provide information to them about their healthcare opportunities. The county workers, the 20,000 or so eligibility workers in the counties, are all receiving training on what this will mean both for Medi-Cal eligible people as well as people eligible for income premiums assistance through the subsidies. And then we'll have a very large and robust public broadcast, television, radio, bus stops, flyers. All of this has been funded through the Affordable Care Act and will be launching. And I know there's a lot that I hear often at the as the chair of the Exchange Board, that people are eager. When is it going to start? How are they going to know about it? But part of it is like going to the dance and not starting the music. We can't really put that level of communication on the street until people can actually pick up the phone or go to the website and do something with the information. So it's all sequencing, and it is all going to fall into place in the fall. I will say, too, that as I said about the IT system and the internet, the ability, we're not going to have everything available at the beginning. And we have a website up now. People can go to coveredcalifornia.com and use a calculator and figure out what they might be eligible for. In October, there will be the capacity for Shop and Compare. It will transition to the enrollment, and we'll be out there on all of these fronts with the communication and the technology to support it. But to the point about, I wanted to be more broad about the specific issue of the access and the signage and the opportunities for people to know what they have are available. This is where I think we're going to have to be a little bit patient. We're not going to flip a switch and have everything working perfectly right at the beginning. This is going to take some time to transition. We have relationships with our plans. They are the contractors that we rely on to enforce the requirements of their networks. And so it takes some time to identify where the problems are and go out and get the problems corrected. And we're going to have to rely on people like you to let us know where there are weaknesses, and we'll begin to address them. But we're also going to have some patience. Everything isn't going to get solved overnight. Thank you.
And then, in particular, Randy, to your question, I think was yesterday as well as we'll go to today, in the LIHP transition plan, lays out the process for informing those over 600,000 on the LIHP program today, and there'll be notices going out. This is where the partnership between the county LIHPs and the state on engaging these populations and continuing to get them notices over the coming months. And if you look in our draft transition plan, it lays out those timing. Thanks.
Okay, the participant at the second mic, please.
Good morning. Sawait Hesjiasim with Health Access. My question is around outreach, recognizing that outreach is going to be very important to ensure that we get as many people enrolled into healthcare as possible. What is the state planning to do around outreach to Medi-Cal eligible populations, given the fact that monies have been made available in the state budget to do outreach to this population?
So as part of the budget, funding was enacted and signed into law by the governor for two pieces. One, to allow for reimbursement for enrollment counselors for enrollment into Medi-Cal, and there's roughly about $24 million set aside for that. In addition, I think it's roughly 28 million was set aside for community-based organizations to focus on outreach and enrollment for Medi-Cal, working through our county partners. So what we're going to be doing is, given the experience we've had with low-income health program, what we've seen in many counties with children's health initiatives, is our county partners have developed networks of both with the county, with community-based organizations, of outreach and enrollment both to Medi-Cal populations and particularly focusing on the uninsured, the expansion population, as well as those that are transitioning out of the mental health system, out of the criminal justice system. And so we will be, over the coming months, providing more information about how we'll be allocating it to the counties and the expectations of how they will be contracting with both for in-reach and outreach through community-based organizations, those that focus again on mental health, criminal justice, and targeting uninsured eligible populations for the Medicaid expansion. And so those allocations will be based on uninsured eligibles, and more information will be coming out shortly on that.
Participant at number 3.
Good morning, panel. Shirley Sanamatsu from Western Center on Law and Poverty. Thank you so much for taking time out of your day to speak with us today and for reminding everyone here about all that we've done up to now to enroll so many people who have not had full coverage before or health access to health services, and that they're now on the bridge to Medi-Cal or Covered California. So thank you. The questions I have are in regard to the redetermination process, and also another expression of appreciation for the approval for the optional suspension for the last quarter of 2013 for the LIHP enrollees. Consumer advocates have been very concerned, distressed, and perplexed at the low re-up numbers for the LIHP redeterminations historically, and the ability for LIHPs to suspend redeterminations just increases the numbers for who can stay in the program. So we think it's wonderful. Yesterday we learned that many counties have already informed the state that they will be exercising the option, and we're hoping to hear positive news from Alameda, if you're here, Ventura, and CMSP. If you can take up those suspensions as well, we think that would be great. My question is actually for Dr. Nagle. On the deferred redeterminations in January through March, you'd mentioned that that's a separate approval process. It's under consideration. Western Center, National Health Law Program, and 17 organizations submitted detailed comments to the revised transition plan yesterday. One of our recommendations was to ask for 1-year deferred redetermination for those enrollees as well, to provide symmetry with the late 2013 suspensions. Can you describe a little bit more about what that process is for consideration and how stakeholders can be part of that discussion?
It actually shouldn't be that complicated. We've already granted approval in Hawaii, and we're basically just asking the states to send us a note after we have stock language telling us that they want to have that option. And again, I think the only reason the fact that we came out with the approval for the October through December period, and we haven't done the January through March period, don't read anything into that other than the fact that we had an email a week before the end of July saying that some counties needed to know then that they had to have the approval for October because they had to get their systems going. So we had to, in fact, I don't really know. I know we've given approval for the October through December period. I'm not quite sure it's actually been put in writing, but we got something out, at least by email, I believe, to the state because we knew, I think it was LA County that was saying, we've got to program this August 1st. So it's not any more complicated for January through March. We were just under the gun for the October period. It shouldn't be a big issue.
Thank you.
Okay, participant at number 2.
Hi, I'm Nina Weiler Harwell. I'm with AARP. Hello. And again, I also want to thank you for this opportunity to hear what's going on and to ask questions. I also have a question about redetermination. Even beyond the LIHP populations, where is that redetermination occurring? Is it occurring in the counties, or does it come up to the state? And if so, how's that going to be handled?
Well, I think first take it on a high level. As I mentioned, the transformation to modified adjusted gross income is changing a lot of the rules on eligibility as well as redetermination. So on redeterminations, for populations under MAGI, if all their information is verified electronically and continued to be verified electronically, then the redetermination will happen just electronically, and there will be no reaching out. If there is a need then to be redetermined, then it goes through a pre-populated renewal form that's sent to them via the counties, and the counties will send them that form, and they will send back the information to the county to do the final determination. So we'll see over time how many, as we move more to electronic databases, how many will be verified electronically, how many will need to submit information to have their redetermination done based on returning information.
Thank you.
Okay, and I think we'll take one more question for the person at the mic number 2.
Thank you. I'm Abby Corsall with the National Health Law Program. I want to add my thanks to everyone for your time this morning. It's really wonderful to see you all and to hear about all the great things that have happened over the last few years here in California. My question is specifically for the HCCI enrollees, and I was wondering if anyone could speak a little bit more about the outreach that will be specifically directed to those enrollees who will have to go through a new application process, go through the CalHERS system in order to determine what type of coverage they'll ultimately be eligible for, and whether you can tell us a little bit about how Covered California and DHCS will be collaborating on that process.
What I can say is this is a piece of the transition plan, and it's an important piece, is to work with Covered California. And I'm sure that Alan and Brian and others will be talking, if they didn't yesterday, talk more about this, about what we're doing with Covered California, whether it's going to be, through notifications, through the service center to reach and help them, but they will have to go through the Covered California, through CalHERS, to have a new application given they're above 138, and they'll be screened and enrolled under MAGI. And the expectation most will be eligible for advanced premium tax credits. Some could, it turned out, under MAGI be eligible for Medi-Cal, but there will need to be a process, and that's where we dive deeper in the transition plan. Thank you very much.
Yes, we'll be ending the session now, and please write your question down and we can follow up. So please join me in thanking our distinguished panel this morning. So now, I'd like to introduce you to Sarah Brooks. She's Chief of the Program Monitoring and Medi-Cal Policy Branch in the Medi-Cal Managed Care Division of the California Department of Health Services. She's going to provide us with some lessons learned from other transitions of populations into Medi-Cal managed care and how those lessons are helping to shape the LIHP transition. And a little bit about Sarah. She is responsible for maintaining and monitoring quality of care within the Medi-Cal Managed Care Program. And previously, she worked for the California Association of Public Hospitals and Health Systems as the Assistant Director of Policy. And while in that position, she focused on healthcare coverage issues with a specific emphasis on the Medicaid and uninsured populations. Thank you, Sarah.
Thank you,
I was trying to sit down just because I'm tall and the microphone never works for me, just So anyways, is there? There we go. Do you have a clicker? So good morning, everyone, and thank you, Jolene, for the introduction. All right, there we go. So just a few general comments. I think that all of you are very aware of the fact that the department has been transitioning many populations to Medi-Cal Managed Care and is also working right now on expanding managed care to additional areas of the state. Specific examples of those are the transition of the Seniors and Persons with Disabilities program, the Healthy Families shift from Healthy Families to Medi-Cal, and also the expansion of managed care to the 28 rural counties in California that currently do not have managed care. It's important to us to leverage the experiences of the transitions, make sure we take forward the learnings from each to the next, so that we can ensure that we build on what we've put in place, but also modify and adjust it based on the transition that we're working on at the time. We really do look to multiple places for this information. One such place recently, CHCF actually conducted an SPD transition survey, and you'll hear me talk a little bit about that today. So we look to surveys such as those for information. We have monthly and quarterly monitoring reports that we receive from our health plans. We utilize the data that's submitted also, such as utilization and counter data as well, to better understand the experience. And we also look to you all as stakeholders for feedback about what's happening on the ground. That's very important to us. The next few slides that I'll talk about, or this one and the next few slides, really look at those different venues that we obtain information from in different ways and focus on the opportunities for improvement and also the successes. So in looking at the slide, first, obviously, we always know it's important to plan ahead. I think most of us know that. That seems like a pretty basic concept, but I think that we have identified at the department that it's important for us to look at, focus, and target certain areas in terms of front load planning, as I put up here. For all transitions, we know that there are differences and things that we need to focus on, but specifically I'll talk about here the Healthy Families transition because I think it's similar in that we're really doing a lift and shift of the majority of the population. I think about 90% of individuals will stay with their same medical home, and we hope to increase that percentage as we continue to do the provider matches. That was the experience in the Healthy Families transition, and we really did identify that it was important for us to do a lot of planning to look at provider matches, making sure that we maximize to the extent possible all of the information that we have. Regular monitoring is also important. Jolene mentioned I'm the branch chief for the program monitoring branch. I'm a monitoring person. I'm a data person, which I think can be a little bit nerdy at times, but is exciting to me. I like to take that data. We get monthly data, we get quarterly data from our plans, utilize that and understand what's happening, really allow it to tell us the story of what's happening and what's occurring within that transition or program. Utilization of that data, and you'll hear me talk a little bit more about this later today, allows us to really identify on a monthly basis, so a snapshot initially when we get monthly data from the plans, but then trended forward, understand what's happening. We're able to identify if there's a spike, is there a reason for us to contact the plan, work with the plan, provide technical assistance, identify if this is an issue that's occurring across plans or is it specific to a certain geographic area. And then if we need to, we impose a corrective action plan to ensure that beneficiaries and enrollees are receiving the care that they need to be getting. It's also good for communication in terms of the data that's submitted to us or that the plans provide to us. We get a lot of questions from many of you in the room and from others. And it's, I think, important to the department that we're transparent and we provide as much information as we can. So collection of that data allows us to tell you the story of what's happening, but also allows you to take that information back to your communities, to your providers,